Hello, good afternoon, or at least afternoon for those on Eastern Time. I'm Dr. Paul Szabolcs. I'm at the Children's Hospital of Pittsburgh of UPMC and representing our Division of Blood and Marrow Transplantation and also the Center for Rare Diseases Therapy. In the upcoming 30 minutes or so, I will be discussing our Pittsburgh Protocol, which is a reduced intensity transplant strategy for inborn errors. And then in the following 20 minutes or so, we'll have opportunity to interact, and I would be very happy to answer questions that will be showing up on the screen. So with that brief intro, I'll get started and try to move the slide, which unfortunately didn't move yet. So as you can see, there's no financial disclosure, no competing financial interests. And way in the background, you can see the Children's Hospital of Pittsburgh behind the city of Pittsburgh and the two rivers. So the topic of our presentation today is really inborn errors, or as we also refer to non-malignant disorders. And over the last several decades, there have been a number of these diseases transplanted, and they could be categorized into four major disease categories: hemoglobinopathies with sickle cell disease and beta thalassemia major, being the two key ones; bone marrow failure syndromes with Diamond-Blackfan anemia, dyskeratosis congenita, severe aplastic anemia, Fanconi anemia, and a wide array of immune deficiencies that I'm not going to read through with their various acronyms, and the metabolic disorders. And those will represent a significant fraction of the patients that we evaluate, and leukodystrophies and mucopolysaccharidosis are the two major disease categories here. Metachromatic leukodystrophy, Krabbe disease, and adrenoleukodystrophy are the three major dystrophies. And Hurler syndrome and Hunter syndrome are again the major mucopolysaccharidosis syndromes. And with question mark, we are showing some of the diseases that may also benefit, although not yet proven in studies so far. So the history goes back all the way to 1968 when the concept of transferable lysosomal enzymes was described by Frantantoni and Neifeld. And it was really an experiment co-culturing two defective cell lines which were able to cross-correct each other, fibroblasts from Hurler and Hunter syndromes, with their representing enzymes. And this really has led to development both of cell therapy and enzyme replacement therapy. The key differences are represented on this cartoon here. In the peripheral circulation away from the blood-brain barrier, the capillary wall is more permissive to various enzymes to cross, and the peripheral tissues therefore can benefit from enzyme replacement in liver, spleen, heart, and so on, as opposed to the central nervous system, where the blood-brain barrier is really a whole lot tighter with the gap junctions and the specialized blood-brain barrier, and enzyme replacement has very, very little chance for crossing this barrier, and only cellular penetration through monocytes and other cells could potentially carry the enzyme, which would then be released in a bystander manner. So the very first transplantation for inborn errors was back all the way more than 30 years ago. So as you can see in this slide from the Center for International Bone Marrow Transplant Registry, there have been a number of disorders, with Hurler syndrome being the most popular, and understandably so, with the excellent neurodevelopmental outcomes. Nevertheless, other MPS syndromes, primarily Hunter syndrome, have been also transplanted. And then the various leukodystrophies represent the other significant categories represented by the various percentages. And osteopetrosis also is an error, inborn error, that has been shown to draw attention and bone marrow transplant activity. So the outcome for these disorders is heavily influenced by the available graft source. And clearly, with those fortunate ones who can have an 8 of 8 HLA matched unrelated donor, the outcomes are quite impressive. This is unrelated bone marrow transplant between 2006 and 15 that were facilitated by what was called NMDP and be the match these days. And as you can see, adrenoleukodystrophy and metachromatic leukodystrophy when combined together, and then Hurler syndrome had 80 to 90% survival by 3 years, again with perfectly matched unrelated donors. Unfortunately, matching is not that easy, and this slide is from the New England Journal of Medicine, published about 3-4 years ago, showing the probabilities of matching for adults and for children. And for the sake of the argument where inborn errors are most significant in children, we should focus on this. So these columns, so white Europeans or those of European descent may have 75% chance of finding an 8 of 8 matched unrelated donor, and those who were not in that 75 would benefit from looking for a 7 of 8 matched donor with 97% of them. But this drops down to 76% to African Americans and Black Caribbeans and Black South Central Americans to 66%. With cord blood, a perfectly matched 6 of 6 match unit is actually lower probability because we are talking about a few 100,000 units frozen as opposed to 50-60 million living donors. But once you are willing to accept 4 of 6 matched donors, you can see 99, 98, 95%, 96%, 95%. So 95 to 99%, regardless of your ethnic background, there might be at least a 4 of 6 match unit. Obviously, there have been studies showing the benefits of matching even in the cord blood setting, but there's plenty of evidence that 4 of 6 match transplantation can also be of clinical benefit with acceptable outcomes. So cord blood transplantation, as we know, got its name from the cord that is really draining blood from the placenta, and that just shows how it's cannulated for collection. And then roughly 100, 120 milliliter, 3 to 4 ounces of cord blood is collected into bags that have acid citrate type of anticoagulants, and then these bags would be volume reduced to eventually fit into a 25 ml cassette, which is now the most commonly used bag to freeze. And as you can appreciate, there's, for instance, here an opportunity for a smaller fraction and a larger fraction in case further cellular manipulation was to be done, and this could be separately thought. So historically, it all started back at the New York Blood Center with Pablo Rubinstein, and by now, over the years, as you can see, the various banks that were established, and we are focusing now on the public banks where the cord blood is potentially available for anyone, not just the family where it's collected from. So at least 600,000 cord blood units are banked worldwide. And as you had seen previously, 4 of 6 matches attainable for at least 95% of the children. So what are the outcomes? Before we focus on our Pittsburgh regimen with reduced intensity, let's examine what has been published in various centers that have focused on this transplantation. And clearly in the United States, Duke University and University of Minnesota have been two major centers. And the EuroCourt combined in this particular study that was published just past year, the outcomes, overall survival, event-free survival, and then breaking down disease-specific event-free survival. And as you can see, just survival is quite sobering. By 1 year after transplant, at least 30% of them, the children have succumbed, and by 4 years, it's really only 60% or so survival. And once you look at event-free survival, where graft failure is also accounted, and then examining furthermore the various disease categories, some of them like GLD, which is Krabbe disease, galactocerebrosidase deficiency, globoid cell leukodystrophy, it's at least 40% that would be dead from progression of disease and the combination of the high dose chemotherapy. There is difference in outcome based on symptomatic and pre-symptomatic patients. Pre-symptomatic patients have somewhat better outcomes. Still, in the initial 12 months, 20–25% of the patients succumb to the procedure. And those with symptomatic disease, the progression is quite severe, like Krabbe disease, where half of the patients have already passed by 24 months post-transplantation. And it's important to emphasize myeloablative conditioning, MAC regimens have been historically utilized and considered to be quote-unquote gold standard. But it is quite concerning that the gold standard leads to so high mortality. The HLA match was more recently examined retrospectively by the University of Minnesota group with 106 of these transplants, 82% myeloablative. And clearly, the overall survival was progressively worse by matching. 4 of 6 rounds, 6 match survival seems to be significantly worse than 5 of 6 and 6 of 6. And the event-free survival with at least 90% enzyme also had, even if not statistically significant, but trend for a worse outcome with the matching, and clearly statistically significant. The transplant-related mortality was over 40% with the 4 of 6 matched, as opposed to the other 2 better matched groups. That's partially explainable by graft failure, where graft failure up to 30% was observed in 4 of 6 matched single cords, and 25% in the 5 of 6 matched single cords. Finally, just focusing on a single center experience from Duke University, busulfan cyclophosphamide, breaking down again the various diseases, Krabbe disease, metachromatic leukodystrophy, and so on. The arrow is highlighting the first year is when the most remarkable drop in survival is appreciated. And even a European center that has examined some recent advances in administering anti-thymocyte globulin, giving them early, not giving them at all, or administering them late. While there might be some impact long-term, eventually at the early 1 year time point, still at least 20, if not 25% of patients succumb to the transplant-related complications. Chronic graft-versus-host disease and acute graft-versus-host disease are very important quality of life indicators. That's demonstrated chronic GVH at 2 years, somewhere in the 30% range, which will most commonly lead to prolonged use of prednisone and other agents, prolongation of cyclosporine or other calcineurin inhibitors. So we are arriving with this historical and kind of cross-sectional background to to the question, why pursue reduced intensity conditioning? And clearly, there are a number of benefits. Survival is number one that we can emphasize, that is critical. And there are some delayed toxicities, and that's identified and listed here. And some of them are not even delayed, like cardiac hypertrophy and pericardial effusions that might be seen up to 25% requiring some sort of intervention with pericardiocentesis and so on. And then the various organs with pulmonary bleeding, veno-occlusive disease, hemorrhagic cystitis, and the combination of multi-organ failure could all contribute to the 20 to 45% TRM that we have seen before. And again, since these transplants would be performed for quality of life reasons, not to control leukemia or malignancy, the long-term benefits are critical, and there are a number of organs that could impact performance, thyroid and growth especially, and the delayed effects on secondary malignancies will be obviously also examined. So the potential of benefits of reduced intensity conditioning, number one is to reduce toxicity, but it might also have some other biological benefits. And clearly the question is, would the neutrophil count that theoretically, on this hypothetical curve drops and then recovers with myeloablative regimen somewhere around 21 days after a single unit cord blood transplantation, could it be shorter by reduced intensity, as it will impact less the microenvironment of the bone marrow niche? So that's an area that could also have favorable impact, worth examining. But before we would focus on the Pittsburgh regimen, reduced intensity is really a wastebasket, and identifying here on this again somewhat hypothetical cartoon, maximum intensity being at the base of this triangle with the various myeloablative regimens listed: Flu-Cy, Flu-TBI, Cy-TBI, Cy, and even the Flu-Mel when the Flu-Bu when the busulfan is more than 8 milligrams per kilo should be here. And then reduced intensity represents really a wide range, and that's a critical aspect when somebody examines closely graftment, graft rejection. A particular RIC regimen's engraftment success may be completely different than another, as you will see, and that could be impacted by the various degrees of immunosuppression and also chemotherapy drugs. And obviously the lightest regimens, the minimal intensity regimens, typically use less than 200-300 centigrade of TBI, but those are not optimal for inborn errors, since for many of the diseases a more robust engraftment is needed if one is aiming for instance, normal enzyme levels post-transplantation. So the goals for improving outcomes for us was really to design a new reduced intensity conditioning regimen that's safe and efficacious. And clearly, not only survival is a critical endpoint, even though it's the easiest to score and most relevant in the first 1 year of transplant outcomes, but quality of life, which will have impact on neurocognitive outcomes. And the quality of life can be also scored by monitoring grade 3 to 4 graft versus host disease, and in general, grade 3 or higher end organ toxicity if we look at the CTCA toxicity criteria. And just the prolonged use of certain agents like prednisone for graft versus host disease or autoimmune hemolytic anemia could have significant impact on quality of life and even neurocognitive outcomes. And with these transplants being performed at specialized centers, many times families have to travel a significant distance. The opportunity to have the patients and families return to their home is a critical quality of life outcome. And with the reduced intensity, if we can achieve an earlier discharge from the transplant center with already tapering or potentially even no immunosuppressive medications, that would be also by itself a huge progress. So our clinical trial that I initiated here at the University of Pittsburgh, Children's Hospital of Pittsburgh, has now accrued already 66 consecutive patients with inborn errors. And as you will see, metabolism, inborn errors of metabolism represents the greatest cadre of patients, but primary immune deficiencies and bone marrow failure syndromes are also eligible. The conditioning regimen is something that has historical background, and back in North Carolina, I have already designed a trial with the same agents, where critically to the Campath flu-mel backbone that goes back all the way to London, we have added hydroxyurea and thiotepa to ensure better immunoablation and maximize the injury to the progenitor cell pool in the bone marrow, which in a way will give an opportunity for more effective engraftment. And our graft versus host disease prophylaxis is based on tacrolimus and mycophenolate, with only a 28-day exposure, then rapid wean, potentially even earlier wean if significant viral infections were to appear. And it's requiring filgrastim. We are moving away even from the Q2 weeks IVIG for making it more cost-effective. Otherwise, standard Bactrim prophylaxis for PJP. And what's also significant here is the close monitoring of T-cell reconstitution, as it will have impact on viral reactivation and control of viral reactivation. As briefly we'll allude to, we are using rituximab prophylaxis to prevent autoimmune hemolytic anemia prior to discharge. And a great advance that we've been now practicing is the recryopreservation of approximately 5% of the original cord blood unit on day of transplant, with the opportunity to infuse it a couple of weeks after transplant to boost T-cell reconstitution at a time point when alemtuzumab Campath levels would not interfere with the survival of any of these cells. So, as I've said, there's a great number of patients, and the vast majority we performed was with 51 patients receiving a single unit cord blood transplantation. But there were a few who had perfectly matched unrelated bone marrow donors with less aggressive disease, like adult onset leukodystrophy, or even matched sibling transplantation. So I present them all here, even though the primary focus will be the single cord transplant. And here you can appreciate that there's 25 genetic disorders, so really it's widely applicable. The most common diseases that our center has been addressing is leukodystrophies, as we work very closely with Dr. Maria Escolar and the neurodevelopmental program for rare disorders, where they screen and meet a lot of families from a great distance with some of these inborn errors. Krabbe disease, metachromatic leukodystrophy are the prime examples. And you can see there's a great variety of diseases for hemoglobinopathy, sickle cell disease, and then we also have some thalassemia and bone marrow failure syndromes, Diamond-Blackfan, congenital erythropoietic anemia, and osteopetrosis, while we have a number of immune deficiencies XLP2, bare lymphocyte syndrome, HLH, and PMP deficiency, CGD, IPEX, and so on. So altogether, it's a regimen with a wide variety of diseases, inborn errors where it could be applicable. So focusing on the cord blood, vast majority, as I said, were young patients who can benefit from and need to benefit from rapid access to cord blood. And typically, we can bring patients to transplantation, cord blood transplantation, in 10 days after the initial contacts. The cell dose infused is obviously much higher with bone marrow as opposed to cord blood, looking at 1 × 10⁸, 10 × 10⁷ being the median range for cord blood, and the CD34 progenitor cell dose per kilogram is about 300,000, 3 × 10⁵ per kilo, with the range, as you can see here. We are benefiting from more and more cord blood units being available, but as you can see, there's still 60-some% that get 5 of 6 or 4 of 6 cord blood transplant, and with the bone marrow transplant, as I said, the vast majority would be, if it's unrelated donor, in the 8 of 8 match category. So the conditioning regimen is described here. The backbone with fludarabine for 5 days, melphalan for 2 days, and thiotepa 1 day is the same for both of them, with a day of rest. And the difference is really just the alemtuzumab dosing, where overall there's a de-escalation of alemtuzumab, as you will see in the next slide, and the distance is going from intermediate to more distal for the higher dose in the transfusion-dependent anemias. We designed 3 strata. The vast majority of them would get after cell test dose of 0.2 mg per kilo and 1 mg per kilo alemtuzumab, as long as they have a normal absolute lymphocyte count. And it's normal at different age groups, meaning different. So more than 2 years old, an absolute lymphocyte count over 1,000 is normal. And these patients would have no significant infections. We will de-escalate alemtuzumab in the presence of infections, and that would be primarily cytomegalovirus, adenovirus, parainfluenza 3, RSV, by respiratory viral battery or stool viral cultures that we perform at the time of initial screening. And similarly, we would also de-escalate the alemtuzumab if the lymphocyte count was lower. And those who have a very low lymphocytes, less than 1,000 at 2 years, or even if it's more than 1,000, but they have a presence of significant infection, then these patients would receive only the test dose 0.2 mg per kilo. So with this approach, we have been able to bring a few patients, even with recent infections, cytomegalovirus and parainfluenza virus infections. So of the 51 patients who received consecutively single unit cord blood transplants, the median time of neutrophil engraftment is 15 days. And this is about 6 days, almost a week shorter than myeloablative regimens would provide in the single unit cord blood transplant setting. And platelet engraftment is also fairly early, 32 days post-transplant. And once it gets started, over 50,000 we attain in another 3-4 days subsequently. So basically all patients at the time of discharge, which is just about this time, of platelet engraftment will be transfusion independent in the outpatient setting. And in terms of engraftment success, Out of the 51 patients, 2 patients have encountered a secondary graft loss with autologous recovery, as they were rejected approximately 38 days, actually both at the same time, post-transplant, in the context of some viral reactivation. Nevertheless, 2 out of 51 is still an engraftment failure not exceeding 5%, and extremely gratifying. And both patients have successfully been retransplanted in about 3 months afterwards. The chimerism is predominantly a full donor chimerism. So you can see the dark blue represents over 95%, 90 to 95%, and so on. So the vast majority will sustain over 95% chimerism. One patient dropped down, but by 1 year was over 25% with osteopetrosis. As you can see, the probability of full donor chimerism is over 65%. And the enzyme levels for patients even below 90 or 95% is still within the normal range for inborn errors. Graft versus host disease, since we have alemtuzumab that at day 0 is still present in the circulation, in some ways there's an in vivo T cell depletion. So the severe grade 3 to 4 GVH acutely we see only about 10%, and about a third or less than a third of the patients will require prednisone or systemic immunosuppression. And most critically, none of the patients developed extensive chronic GVH. The overall survival at 2 years is 92%, and the TRM really at 1 year is somewhere around 4 or 5%, with 2 patients succumbing to adenoviral disease. This patient actually arrived with both of these viruses, and there were 3 other deaths due to progression of underlying disease with Gaucher and metachromatic leukodystrophy at later time points, not related to the procedure. So the event-free survival at 3 years is 90%. Viral infections are still present, especially this young age group with the median age group 1.5 years of age. This is comparable to what's been seen with ATG containing regimens. That's all viral infections, and adenovirus is potentially leading, although other viruses are present. We are not screening routinely for HHV6, but we do screen twice a week for cytomegalovirus and adenovirus. As I said, only 2 out of the 51 cord blood recipients have actually developed severe disease that failed subsequent cell therapy as well and succumbed to it. So the vast majority we can control with antiviral agents such as cidofovir. Immune reconstitution with the de-escalated and personalized to some degree risk stratified CAMPATH has been gratifying really fast. So you can see here pre-transplant we measure their immune profile, either T cell receptor excision circles or the T cell receptor diversity score, and at 30 days they drop down, reflecting the immunoablation. But the diversity in the blue line is already starting to recover at 3 months and reaching basically normal by 6 months, while the thymic rebound starts somewhere between 3 and 6 months, and by 9 months is fully appreciable and continues to rise. And this is appreciated here in T cell receptor diversity as a Gaussian normal T cell receptor B beta 2 family is also recovering by 6 months post-transplant. Not quite the same score, 175 to 135, but clearly a diverse repertoire that permits this patient to be already back home several hours away from our center of immunosuppression. Donor lymphocyte infusions is something that I alluded to as a new, very simple technique. When we refreeze 5% of the original cord blood unit, the families give independent consent for that, and it's being held in the freezer unless we are concerned a couple of weeks after transplant for either low donor chimerism in the T cell fraction, persistent viral infections, or overall delayed immune reconstitution. So here we can see, for instance, those who were infused for chimerism concerns, the T cell chimerism at the time of infusion of the donor leukocyte infusion, and subsequently, even the 5% cord blood has about 500,000 or so T cells per kilogram as a median number, and in the absence of any lingering serotherapy, in this case alemtuzumab, they can undergo peripheral expansion and contribute to a higher and higher degree of donor T cell chimerism. And similarly, for those where we infused it for viremia, the majority of the patients seem to have a decline in viremia, and the overall T cell counts have been rising regardless of chimerism, just overall T cell count post DLI. So this is a very affordable and very simple tool that we are employing now, probably about 2/3 of our patients. So to summarize, this Pittsburgh Reduced Intensity Protocol, it's the largest single center and any series in a prospective trial to examine single unit cord blood for inborn errors, and we're very pleased that over 95% or at least 95% donor engraftment is attainable with a very low mortality. And those inborn errors of metabolism where we can measure enzyme level like Hurler syndrome or Krabbe disease, metachromatic leukodystrophy, even those who have 75% or 87% or 69% chimerism potentially will have normal enzyme levels. Again, the vast majority will be with at least 90% donor chimerism. And we haven't detailed it, but the end organ toxicity, now that we have gotten to 67, we have seen the first 66 first patient of veno-occlusive disease responded well to the fibrotide. No patient with pulmonary hemorrhage or hemorrhagic cystitis leading to gross hematuria, and none of the pericardial effusions. So our goals to earlier discharge is attainable in the vast majority, somewhere between 6 to 9 months. At 6 months, they probably will be still tapering, and by 9 months, many of them have completed tapering of their immunosuppression. So with this slide, I would complete the presentation and have opportunity for responding to questions, and I would really like to acknowledge the team, the stem cell laboratory, the physician colleagues, and the outstanding nursing, and Mark Wendelucht, who has worked closely with me on this protocol, and my colleagues currently, and from the referral team, especially acknowledging the NDRID program. And we're benefiting from a vast array of experts that help with either the management or the disease-specific follow-up, and I'm highlighting that. So with this, I would stop here, and hopefully we'll have now the opportunity to start responding to questions that those of you who are listening are sending in. So, reading a question.
You got them. Okay.
Jay is asking, if my child has BMT, will they still need enzyme replacement for Hunter syndrome? That's a great question. We have taken now practically all our MPS referrals have been on enzyme replacement, and we stop enzyme replacement once engraftment is accomplished, so no later than 3 weeks after Cordless transplantation. So our answer is no, we don't believe, and most importantly, Dr. Escolar, who is leading the outcome analysis, doesn't believe that additional enzyme replacement is necessary. Another question I'm reading, if my child has a transplant, will my child be able to have gene replacement therapy if that becomes available? I think it's an excellent question. Again, since the engraftment will introduce the missing enzyme, even those who had no enzyme exposure and potentially would be developing antibody, neutralizing antibody to ERT or gene therapy, will not do so. In a way, transplantation is a tolerizing measure. So yes, your patient, your child would be eligible for gene replacement therapy subsequently if we think further intervention is justifiable. How do you evaluate whether a rare condition would be a good candidate for transplant? That's another question. That's a great question again. We rely on our expert collaborators and mostly team from genetics and metabolism, led by Dr. Jerry Buckley, or Maria Escolar from the Program for Neurodevelopment and Rare Disorders, who have been advising us and helping us with many tumor boards for some of the rare diseases where this is indeed a question, or diseases where it has not been performed. Jonathan is asking me for a transplant if it has been performed for LCHAD deficiency, long chain fatty acid disorder. I'm just guessing. So we are performing it for, obviously, for adrenoleukodystrophy, and now we are about to perform for ABCD5 deficiency as a first of its kind, but I'm not so sure if LCHAD was ever transplanted elsewhere, but we have not performed it yet. This is the last question that I see. That was the last question. He left.
There's a question if they could be a donor for their child. The parent could be a donor for their child.
There's someone who's inquiring if the parent could be a child, and the answer is yes. We don't typically perform such transplants, which is called haplo-identical transplant. We have performed a parental transplant with some HLA mismatch. We believe for most children we would find a suitable cord blood unit. This question is really relevant for teenagers or adults where somehow cord blood would not be suitable based on limitations in cell dose. Otherwise, we feel very comfortable with, based on the outcome, either 7 of 8 unrelated bone marrow or 4 of 6 unrelated cord blood. And we are developing now T-cell depletion methods and protocol for sickle cell disease. Actually, it's already on clinicaltrials.gov, where 6 of 8 matched unrelated healthy donors would be chosen as donors. So we are not a haplo center where parental donors are preferentially chosen. Well, I think with no further questions, I wanted to thank all of those who listened in, and again, it's our pleasure to help so many families coming from a wide distance from West Coast to out of the States, and thank you again for your attention.